Good evening, all.
Good
Hope I'm
evening.
audible.
Yeah, sure.
Okay, we welcome
evening.
you.
Good
We
evening.
welcome you for
Good
this
evening, Sandeep.
Environment, Occupation and Health PG webinar, Series 1, Issue 77. And today's topic will be AP updates by Dr. Rajiv Jain, as usual. And also we'll have a panel discussion on COVID testing mandate, policies, guidelines with industries with various eminent doctors. So to start with, we'll start with Dr. Rajiv Jain's AP updates as usual. So as we all know, Dr. Rajiv Jain is the Vice President of AUOHD, who doesn't require any introduction. He's well known in India and the entire world in occupational setting in the world. So he's a senior consultant health, Indian Railways, New Delhi. He has got over 40 years of experience in health and hospital administration, fellow award of Indian Public Health Association, fellow award of Association of Environment and Occupational Delhi. He has published, presented more than 145 scientific papers in national and international conferences, journals, and books. So it's a great privilege to hear to Dr. Rajiv Jain as usual. Sir, the floor is yours. Please start with presentation, sir.
Thank you, Dr. Guru Prasad. It's such a pleasure to have you here as the moderator once again. So on Saturday, the 6th of November 2021, here we are again to review the epidemiological situation of COVID-19. Sitting in India, people start feeling that COVID-19 is gone. But has it? Let's see the situation in the entire world, region, and our cities, our states, and the real situation on the ground. Then we should observe the facts and decide where are we? Are we out of the pandemic or not? So let's examine this aspect. But before that, we are in the midst of the global climate change conference in Glasgow. Our Prime Minister had gone there, and the entire world is looking at the outcome of the climate change conference. And today, there was a global conference on health and climate change as well by the World Health Organization. So before I start, I would like to share with you a video, the voice of a girl from India in Glasgow. So have a look and listen to her.
For the next 2 weeks of COP26, we will speak about our future. Deadlines, milestones, hopes, and fears. I, however, am not here to speak about the future. I am the future. In 2030, by when we must halve our carbon emissions, I'll be just 24 years old. By 2050, when we will assess whether net zero has been achieved or not, I'll be in my early 40s. And by 2100, hopefully still going strong at 94. The point is that me and my generation will live to see the consequences of our actions today. Yet none of what we discuss today seems practical to me. You are deciding whether or not we will have a chance to live in a habitable world. You are deciding whether or not we are worth fighting for, worth supporting, and worth caring. Many of my generation are angry and frustrated at leaders who have made empty promises and failed to deliver. And we have every reason to be angry. But I have no time for anger. I want to act. I'm not just a girl from India. I'm a girl from Earth, and I'm proud to be so. I'm also a student, innovator, environmentalist, and entrepreneur. But most importantly, I'm an optimist. Today, I ask, with all due respect, that we stop talking and start doing. We, the Earthshot Prize winners and finalists, need you to back our innovations, projects, and solutions, not an economy built on fossil fuels, smoke, and pollution. We need to stop thinking about old debates because we need a new vision for a new future. So you need to invest your time, money, and effort in us to shape our future. Now, just before we started the Earthshot Prize, we all watched a video in which the former US President John F. Kennedy gave his legendary moonshot speech. And here, on the COP26 stage today, I would like to update that speech for the Earthshot Prize. We, the Earthshot Prize winners and finalists, choose to, by the end of this decade, to protect and restore our nature, clean our air, revive our oceans, build a waste-free world, and fix our climate. And we are the proof that the greatest challenge that the history of our Earth has ever seen is also the greatest opportunity. We lead the greatest wave of innovation that humanity has ever known, and we choose not to complain, but to take actions that will make us healthier and wealthier. And we choose to do these things not because they are easy, but because they are hard. And rising to these challenges will shape a new generation, a generation that will build a better world for all of us and generations to come. And on behalf of the Earthshot Prize winners and finalists, I invite you to join us. I invite you to stand with us. And we hope that you will give up the old ways of thinking and the old habits. But let me be clear, when we invite you to join us, we will lead even if you don't. We will act even if you delay. And we'll build the future even if you are still stuck in the past. But please accept my invite, and I assure you, you will not regret it. And finally, just remember, when it comes to climate change, there is no stop button. We can't hit pause or even rewind. We can only move together towards the future. So, united we rise, and together we will definitely succeed. Thank you.
So, you heard the voice, the global voice from India, and the pandemic and the epidemiological aspect of the pandemic COVID-19 are a local and global assimilation of the environmental challenge. And COVID-19 is the best example of our neglect for the environment and the price we have to pay. So let's examine the epidemiological situation of COVID-19 today. Let's go ahead and listen to the first good news this week, the 3rd of November, 2021. WHO issued emergency use listing for the 8th COVID-19 vaccine, and that vaccine was developed very much in India. Next slide. This is really a shot in the arm because WHO's not will allow countries to import and administer Covaxin. Multilateral bodies can also procure the jab for distribution worldwide, and Covaxin has been approved in 14 nations and 50 more are in the process. Next slide, please. On 3rd of November, the World Health Organization issued an emergency use listing, EUL, for Covaxin developed by Bharat Biotech, adding to a growing portfolio of vaccines validated by World Health Organization for the prevention of COVID-19 caused by SARS-CoV-2. WHO's EUL procedure assesses the quality, safety, and efficacy of COVID-19 vaccines and is a prerequisite for COVAX vaccine supply. It also allows countries to expedite their own regulatory approval to import and administer COVID-19 vaccines. This emergency use listing expands the availability of vaccines, the most effective medical tools we have to end the pandemic, said Dr. Mariangela Simao, WHO Assistant Director General for Access to Medicines and Health Products. But we must keep up the pressure to meet the needs of all populations, giving priority to the at-risk groups who are still waiting for their first dose before we can start declaring victory. Covaxin was assessed under the WHO EUL procedures based on the review of data of quality, safety, efficacy, a risk management plan, and a pragmatic suitability. The technical advisory group, that is TAG, convened by WHO and made up of regulatory experts from around the world, has determined that the vaccine meets WHO standards for protection against COVID-19, that the benefit of the vaccine far outweighs the risks, and the vaccine can be used globally. The vaccine is formulated from an inactivated SARS-CoV-2 antigen and is presented in single-dose vials and multi-dose vials of 5, 10, and 20 doses. Next slide, please. Covaxin was also reviewed on 5th of October by WHO's Strategic Advisory Group of Experts, that is SAGE, on immunization, which formulates vaccine-specific policies and recommendations for vaccines used in populations, that is recommended age groups, interval between doses, specific groups such as pregnant and lactating women. The SAGE recommended use of the vaccine in 2 doses with a dose interval of 4 weeks in all age groups, 18 and above. Covaxin was found to have 78% efficacy against COVID-19 of any severity, 14 or more days after the second dose, and is extremely suitable for low and middle income countries due to easy storage requirements. Available data from clinical trials on vaccination of pregnant women are insufficient to assess vaccine safety or efficacy in pregnancy. However, initial studies were reassuring. The vaccine has been given to over 120,000 pregnant women in India, with no short-term adverse effects noted. Further studies in pregnant women are planned. Next slide, please. What is WHO emergency use listing? The emergency use listing, that is EUL procedure, assesses the suitability of novel health products during public health emergencies. The objective is to make medicines, vaccines, and diagnostics available as rapidly as possible to address the emergency while adhering to stringent criteria of safety, efficacy, and quality. The assessment weighs the threat posed by the emergency as well as the benefit that would accrue from the use of the product against any potential risks. The EUL pathway involves a rigorous assessment of late phase 2 and phase 3 clinical trial data, as well as substantial additional data on safety, efficacy, quality, and a risk management plan. These data are reviewed by independent experts and WHO teams who consider the current body of evidence on the vaccine under consideration, the plans for monitoring its use, and plans for further studies. As part of the EUL process, the company producing the vaccine must commit to continue to generate data to enable full licensure and WHO pre-qualification of the vaccine. The WHO pre-qualification process will assess additional clinical data generated from vaccine trials and deployment on a rolling basis to ensure the vaccine meets the necessary standards of quality, safety, and efficacy for broader availability. Next slide. What is SAGE? SAGE is the principal advisory group to WHO for vaccines and immunization. It is charged with advising WHO on overall global policies and strategies, ranging from vaccines and immunization technology, research and development, to delivery of immunization and its linkages with other health interventions. SAGE is concerned not just with childhood vaccines and immunization, but all vaccine preventable diseases. SAGE assesses evidence on safety, efficacy, effectiveness, impact, and programmatic suitability, considering both individual and public health impact. SAGE interim recommendations for EUL products provide guidance for national vaccination policy makers. These recommendations are updated as additional evidence becomes available and as there are changes to the epidemiology of disease and the availability of additional vaccines and other disease control interventions. A little bit more about SAGE. Next slide, please. This is the team which is currently constituting the current Strategic Advisory Group. The chair is Dr. Alejandro Cravioto. He is affiliated with the Faculty of Medicine of the Universidad Nacional Autónoma de Mexico. He's from Mexico. But out of the 15 members of the SAGE are currently there is one from India. And he is top left, you're seeing Professor Rakesh Agrawal. And another Indian who is working in US, Dr. Sonali Kochhar. So out of 15, 2 are from India, and they are in SAGE of the WHO. Let's understand who these individuals are. This is the entire list of current members of SAGE, 15 members. And on the top, after the chair, number 2 is Professor Rakesh Agrawal, who is from Jawaharlal Institute of Postgraduate Medical Education and Research, Jitmer, Pondicherry, India. He is there as a member till October 22. And on number 5, you find Sonali Kochhar from the University of Washington, Seattle. She is there till December 23. So this is a rotating membership. Each person remains for 3 years, and he can be reappointed for a second term. Next slide, please. Dr. Alejandro Cravioto is the chairman, he was born in Mexico City in 1947, received the medical degree with honors in 1973 in the Faculty of Medicine of the National Autonomous University of Mexico. He specialized in pediatrics from 1973 to 1976 at the National Institute of Pediatrics in Mexico City, followed by training at the London School of Hygiene and Tropical Medicine of the University of London, receiving a diploma in tropical public health in 1977 and a PhD in 1981. So he is the current chairman of SAGE. Next slide, please. Professor Rakesh Agrawal, he's the director of Jawaharlal Institute of Postgraduate Medical Education and Research, Pondicherry, India. Rakesh Agrawal, MD, DM Gastroenterology, MSc Epidemiology, is the director of the Jitmer, Pondicherry, India. He previously served as professor of gastroenterology at the Sanjay Gandhi Postgraduate Institute of Medical Sciences, Lucknow, India. Professor Agrawal obtained his medical degree at All India Institute of Medical Science in New Delhi in 1983 and received his residency training in internal medicine at the same institution during 1984 to 1986. Thereafter, he completed his fellowship in gastroenterology at the PGI, Chandigarh, India during 1987-89. In addition, he has trained in lab techniques in the hepatitis branch, Centers for Disease Control and Prevention, Atlanta, USA during 1995-1997, and completed a degree in epidemiology from the London School of Hygiene and Tropical Medicine in 2008. And he is one of the members of 15 experts which consider any vaccine to be given approval by the WHO for inclusion in the EUL. Next slide, please. Here is Dr. Sonali Kochhar. She is the clinical associate professor, Department of Global Health, University of Washington, Seattle, and medical director of the Global Healthcare Consultant. Dr. Sonali Kochhar, MD, has over 2 decades of leadership experience for global phase 1 to 4 clinical research, safety, and epidemiology studies, and implementation research for vaccine and drugs conducted in the USA, Europe, Africa, and Asia in adult, maternal, and pediatric populations, infectious disease, including COVID-19, HIV/AIDS, influenza, Zika, malaria, tuberculosis, Guillain-Barré syndrome, respiratory syncytial virus, diarrheal, and tropical diseases, maternal immunization, pandemic preparedness and response, introduction of new vaccines, increasing immunization coverage and work and acceptance, translating research into impactful immunization programs by policy, strategy, and communications development and healthcare systems, strengthening and clinical data sharing. Her work has informed global and country-specific vaccine policy recommendation. She has led multiple research projects in Kenya, Uganda, Zambia, Gambia, South Africa, United States, Belgium, Germany, India, Bangladesh, and Nepal. She has led multi-country clinical development programs for vaccines and the development and management of the clinical project strategy, clinical development plans, clinical and regulatory strategies, safety assessment, and pharmacovigilance, including risk management plans and benefit risk assessment. So you can understand the expertise that is available at the WHO level is truly global, and they are the best scientists, including best scientists from India. Next slide, please. Next slide, please. Another development of significant importance is these two pills that look to transform the COVID battle. Pfizer's experimental antiviral pill for COVID-19 cuts the rate of hospitalization and death by nearly 90%, 90%. The company said on Friday, that is yesterday, a day after the UK greenlit Merck and Company's antiviral drug, which claims to halve the risk of hospitalization or death from COVID. A look at how these two pills may transform the world's battle against COVID. Why a pill-based treatment is crucial. Currently, nearly all COVID-19 treatments being widely used require an IV or injection. Researchers worldwide have been racing to find a pill against COVID-19 that can be taken at home to ease the symptoms, speed recovery, and reduce the crushing burden on hospitals and doctors. To buttress vaccination, a pill is useful. Experts stress that vaccination still remains the best way to protect against infection. But with billions in the world still unvaccinated, effective, easy-to-use treatments will be critical to curbing future waves of infections. So let's look at the first pill, Paxlovid by Pfizer. Previous slide, please. Paxlovid by Pfizer, it reduces the risk of hospitalization or death by 89%. Pfizer's drug called Paxlovid achieved an 89% reduction in risk of hospitalization or death among adult patients with COVID who are at high risk of progressing to severe illness, the drug maker claimed. The findings are 1,219 unvaccinated adults were part of the drug trial. In the treatment group, 0.8% people were hospitalized. There were 0 deaths. In the control group, 7% people were hospitalized and there were 7 deaths. We were hoping that we had something extraordinary, but it's rare that you see great drugs come through with almost 90% efficacy and 100% protection and death. This is what Dr. Michael Dalston, Chief Scientific Officer of Pfizer, said. How it works. The drug binds to an enzyme called a protease to stop the virus from replicating itself. Some drugs for HIV work in a similar way. Approval is sought. Pfizer said it will ask the US FDA and the international regulators to authorize pill as soon as possible. Once Pfizer applies, the FDA could make a decision within weeks or months. The second drug is Molnupiravir by Merck. It reduces by 50% the risk of hospitalization or death. Merck's COVID-19 pill was on Thursday approved in Britain, which became the first country to approve a potentially game-changing treatment. It will be administered as soon as possible following a positive COVID-19 test and within 5 days of the onset of symptoms, the regulator said, citing clinical data. The findings of the clinical data are 775 unvaccinated adults were part of the drug trial. In the 5 days of treatment, the pill dramatically reduced the rate of hospitalization. In the treatment group, there was 7.3% people who were hospitalized and there were 0 deaths. In the control group, there were 14.1% people who were hospitalized and there were 8 deaths. How it works? Molnupiravir is designed to introduce errors into the genetic code of the coronavirus and is taken twice a day for 5 days. The rollout already being planned. Professor Stephen Powis, National Medical Director of the National Health Service, that's NHS in England, said the drug would be administered to patients at higher risk of complications. A wider rollout will follow if it is shown to be clinically and cost effective. Current options, as you know, are Gilead's infused antiviral remdesivir and generic steroid dexamethasone. However, these are generally only given after a patient has been hospitalized and are administered by IV or injection at hospitals or clinics. So we have a wider range of antiviral drugs, oral as well as intravenous. Next slide, please. Vaccine laggards pick pace to add to festive cheer. States such as Telangana, West Bengal, and Tamil Nadu struggled to keep pace with the rest of the country when India began rolling out the COVID-19 vaccine earlier this year. However, in the last two festive months, these three states, along with Maharashtra and Assam, have picked up speed and doing better than high-performing states and even national average, the data shows. As a group, these five states, that is Telangana, West Bengal, Tamil Nadu, Maharashtra, and Assam, have given 452 doses per 1,000 population at the end of August, 6.6% less than the national average. 2 months down, the cumulative coverage of in these two states has increased to 844 doses per 1,000 population, exceeding the national average of 780. These states were performing poorly for different reasons. Tamil Nadu faced high vaccine hesitancy, with 42% people unwilling to get vaccinated earlier this year. According to a survey by Facebook with the University of Maryland and Carnegie Mellon University, its vaccination coverage was 427 per 1,000 population at the end of August. However, the state organized series of mass vaccination camps, including 7 since mid-September, even as vaccine hesitancy started reducing after the second pandemic wave. As a result, its vaccination coverage jumped by 80.6% to 771 doses per 1,000 at the end of October. During this period, Telangana and West Bengal have each increased their coverage by 79% and 89% respectively. All the states except West Bengal administered fewer doses in October than they did in September. However, some states are yet to pick up pace. Meghalaya, Jharkhand, Nagaland, Bihar, and Uttar Pradesh have each administered less than 600 doses per 1,000 population. Next slide, please. This is what the data shows. Telangana, West Bengal, and Tamil Nadu accelerated the most among states lagging in vaccination coverage. August is in gray, pink is September, and red is October. And if you look at Telangana, West Bengal, and Tamil Nadu, how effectively they have accelerated the pace. Next slide, please. This is the international reality. Bangladesh reclaimed top spot in vaccination coverage growth. Bangladesh reported the best growth in vaccination coverage last week among the most populous countries after 3 weeks. It received 1 million doses of Covishield from India under its vaccine Maitri program. Bangladesh government plans to inoculate half of its population, or 80 million people, by January. So far, it has vaccinated 40 million with at least the first dose and has also started vaccinating children aged 12 to 17 starting 1st of November. Indonesia and the Philippines have slid down to the third and the fourth places as Mexico jumped to the second spot for the first time. Earlier this week, Mexico received 6.5 million Sputnik V doses and 5.9 million AstraZeneca doses. Pressure has been mounting on Mexico to expand its vaccination program to include children. Meanwhile, Indonesia became the first country to give emergency approval to Covax. So you are seeing the graph in red, the top 5 countries with weekly change in COVID-19 vaccine doses per 100 people in percentage. Bangladesh 17.3%, Mexico 9.4%, Indonesia 7.3%, Philippines 5.7%, and India 4.2%. Next slide, please. Kangra district accounted for 42% of active cases in Himachal Pradesh. In focus is Himachal Pradesh. Himachal Pradesh has been witnessing a steady rise in COVID-19 cases since the first week of October. 8 of its 12 districts have reported more new infections this week than they did in the last. It is the only state in India where more than 50% of the districts have reported an increase in cases. Kangra district, with 756 active cases, accounted for 42% of the total active caseload in the state. It is the first time that Kangra or any other district in the state has reported more than 800 cases since the third week of June. Himachal Pradesh now has 1,796 active cases, highest since the third week of August. On the positive side, the state has the highest vaccination coverage in the country Kangra has vaccinated 71% of the population with at least one dose and 42% with both doses, which will likely keep hospitalizations and deaths in check. Next slide, please. 20 districts reported over 1,000 new cases in the past 7 days. India reported 93,206 new cases this week, down 12.5%. It is the first time the weekly count has slid below 1 lakh since the last week of February. However, 17 states and union territories reported a rise in cases compared to 12 in the preceding week. West Bengal and Jammu Kashmir reported the biggest jump by 309 and 88. Kerala still has nearly half the confirmed cases in India. Ernakulam, Thrissur, Thiruvananthapuram, and Kozhikode are the only 4 districts in India with more than 5,000 new cases each in the last week. India also reported a sharp rise in its death count, but that was mostly because of the reconciliation exercise undertaken by Kerala. Even as the country celebrates Diwali, there is hope that the cases will not pick up after this festive season because of higher zero prevalence this time. Next slide, please. This is the Southeast Asian region where you find the trend is on the death side. If you see on the right bottom, the deaths are increasing while the cases are going down, but not near zero. You find in the cases from India, 9% decrease, Thailand 8% decrease, and Myanmar 9% decrease during the week. In terms of deaths, there was 83% increase in India, and Thailand 7% decrease, and Indonesia there was 21% decrease. The number of deaths in India accounted for 79% of the new weekly deaths in the region. Next slide, please. This is the global situation for the week, and what you find the window of green expanding to the right. If you look at the trend, it is Europe which is taking the major burden of cases. If you look at WHO European region, which reported a 6% increase in new weekly cases as compared to the previous week, other regions reported declines or stable trends. The largest decrease were reported from Eastern Mediterranean region, followed by Southeast Asia and African regions. And new weekly deaths increased by 8%, mainly from Europe. And other regions reported less. Next slide. This is the reality. If you look at change, new cases in the last 7 days percentage, highest percentage is Europe, 59%. And all other regions except Americas are less than 10%. Americas constitute 24%. Change in the new cases in the last 7 days, only positive is 6%, Europe increasing by 6%, Americas 3%, Western Pacific 2%, and all other negative. Globally, it is 3% increase. If you look at new deaths in the last 7 days, out of 100 deaths, 48 deaths occurred in Europe, 30% occurred in Americas, and 10% in Southeast Asia. So deaths are occurring in Europe and Americas. And the change in deaths, if you look at it, 12% increase in Europe and 10% increase in Western Pacific region, Southeast Asia, 50% increase. Total global increase was 8%. Next slide, please. This is the global situation. 248 million confirmed cases, and for the first time, deaths during the week exceeded 5 million. 5 million deaths across the world during the pandemic due to COVID-19 globally. And you see the trend as wave after wave. Next slide. This is a situation with WHO region. And if you look at the trend, this is taken today, and you can see how things are happening. The window, the green is the dominant color and followed by yellow color. Green is the European region and the Americas region is yellow. All other regions are shrinking. In terms of deaths, weekly deaths at the bottom graph, you also see the widest window of green, that is Europe. And the second widest is Americas. Deaths are increasing in Europe. Next slide. These are the trend of the pandemic In Americas, Europe on the top row, Southeast Asia, Eastern Mediterranean in the middle row, and Western Pacific and Africa in the bottom row. And you look at the graph of Europe. On the right, there is sharp increase in the fourth wave. Instead of going down, it is going up, up, and up. Next slide, please. This is the global trend in terms of number. This is updated at 6 p.m. today from the WHO coronavirus dashboard. And you can see yourself, Europe constituted 19 lakh 4,000 cases in the last 7 days out of 30 lakh reported globally. And last 24 hours, Europe again only reported 3 lakh 18,000 out of 4 lakh 84,000 globally. In terms of deaths, out of 47,000 deaths, Europe reported 25,000 deaths. And in terms of 24 hours, last 24 hours, out of 6,869 cases, 4,094 cases were reported by Europe. Next slide, please. Now, look at the cases ranked in terms of newly reported cases in the last 7 days. You can see United States #1 in countries ranking. Russian Federation is second, 282,000. So Russian Federation, which was nowhere in the top 10, is second in the world now. And last 24 hours, Russia itself reported more than 40,735 cases, or new cases in the last 24 hours. United Kingdom is #3 at 272,000. Turkey, Ukraine, Germany, India, Brazil, Poland, and Romania. So you can see dominant is Eastern Europe and also United Kingdom. Europe is the epicenter of COVID-19 in the world at the moment. Next slide, please. This is a ranking of deaths newly reported in last 7 days by country. Out of 47,000 deaths reported globally in the last 7 days, 8,000, #1 is Russian Federation, 8,227. United States second, 7,471. Ukraine third, 3,990. Romania fourth, 3,176. So it is the Eastern Europe, which is the total epicenter for cases and deaths. And you see the dramatic change. 1,192 deaths in Russian Federation in the last 24 hours. And United States, 1,258. Next slide, please. This is the COVID-19 cases per 1 lakh population reported by countries during the 7 days, and the darkest color brown is in Eastern Europe. Next slide. This is the COVID-19 deaths per 1 lakh population, and the darkest color, dark blue, is in Eastern Europe. Next slide. This is the prevalence of variants of concern in the last 60 days, and historic detections data is updated till 2nd of November 2021. If you look at the current Delta on the bottom right is the dominant, and it is the proportion of vaccine of concern among total sequences is dark blue is in the Delta. And you also see a bit of Gamma dominant in South America, while Alpha is only in Southeast Asia region, Indonesia. But globally, if you have to choose one, it is Delta is the dominant vaccine variant of concern globally at the moment. Next slide. Thank you so much for your attention, because attention is the rarest and purest form of generosity. Thank you for your generosity.
Thank you, Dr. Raju Jain. Once again, an excellent presentation. Of course, the news on Covaxin is a great news. One is a national pride, and also the other one is people who got Covaxin now can travel the entire world, and all countries recognize it. That was a great information. And also your coverage of SAGE was very important, because people think that WHO is delaying or something for Covaxin, but there is a process involved. And the SAGE gets involved in that, and they have to approve that. That was really great. And also, we had heard about Dr. Cravioto speak, but we didn't know his background. Thanks for that. We came to know about Cravioto, and also Rakesh Agarwal, and also Dr. Sonali Kocher is involved in that. And also the global scenarios was very alarming, really in the Europe region and also the US. It's a lesson for the entire world. And also, we need to learn from what Spain, Japan, and UAE did, how they reduced the number of cases. So it's really, the world is teaching us a lot of lessons, every country has to learn. So thanks for that, sir. So we have time for just one question. If you have anybody has one question, can you can ask now, or we can take the questions later once we have the panel discussion. I'm not seeing any questions in the chat box. I think we can take it at the later stage. Can I have my presentation, please? Yeah, so we'll start with the panel discussion on COVID testing mandate, policies and guidelines within industries. Of course, this is a question like every industry has now. Should we test or not? Or should we, if at all testing, what test we should do and how we should do? And all those things we'll discuss. Next slide. For that, we have in our panel Dr. Vijay Rao, who is the president IOH. He is the head of medical division and certifying surgeon, nuclear fuel complex, Department of Atomic Energy, Government of India. Welcome, Dr. Vijay Rao, for this panel discussion. And we have Dr. Sandeep Sharma, who is Honorary General Secretary, IOH and AOHD, and he is the General Manager, Corporate HSE, Indian Oil Corporation. And he is having rich experience of 25 years in the field of medical and also health, safety, environment, management of these in Indian Oil Corporation. Welcome, Dr. Sandeep. And we have a next panel, Dr. Rajiv Jain. We just heard a beautiful presentation by Dr. Rajiv Jain. There is no need of introducing. Still, I have, as a panel, I have to introduce him. He is the Vice President of AOHD, Senior Consultant, Health, Indian Railways, New Delhi. He has got 40 years of experience in health and hospital administration, and he has published and presented more than 145 scientific papers in national and international conferences, journals, and books. And also recently is a part of ICO membership, and that we used to read in WhatsApp a lot. Welcome, sir. Welcome for this panel. And the next speaker we have Dr. Kamala Fatyal. She is Vice President AOHD, and she is the Chief General Manager Medical Services at National Hydropower Corporation Limited. And she also holds a diploma in hospital management from AIMS. She has got 33 years experience as a general physician, and in that 30 years in National Hydropower Corporation Limited itself. And she has done a lot of work in an organization. We'll come to know when we talk to her. And the last panelist, we have Dr. Ramanjit Singh, is a manager, medical and occupational health for Hindustan Unilever Limited. He has got 14 years of experience in occupational health, well-being, resilience, sports, and emergency medicine. And welcome, Dr. Ramanjit. Welcome all the panelists. Can I have the next slide? So next slide. Yeah, so we'll just have a framework for the discussion today, because whenever we talk about the strategies of testing, we need to have the history of testing. When it started, how it started, and what was happening, and now how it has evolved. So we'll talk. We'll spend about maybe 20% of the time on the first wave, how the testing evolved, what was strategy, mass testing, what we did, and testing workplace entry and limitation of testing. Second slide. And then we'll spend around another 20% of the time in on the second wave, what improved in second wave, how the testing evolved in industries, how industries were testing, and how easy was it, and also the stigma was not there if somebody is positive. So all these things we'll talk in the second wave. Next slide. So and the present, with the advent of vaccines and people getting vaccinated, so what should be the strategy for industries? Of course, government keeps on changing the guidelines, but as industry experts, what do we think is the right way of testing? What testing, when we should test, whom we should test, and when we should avoid testing? So all this we can discuss. Can I go 2 slides prior as a first wave? So with this panel, let us start. I welcome Dr. Vijay Rao. Sir, like what was the strategy in your industry during first wave? Can you give us in maybe a minute a brief discussion? Like what was it, in first wave? What was the strategy of your organization? Whether you were going to test, how was it in the first wave?
Good evening. Good evening, all the speakers. At the outset, I would like to thank the organizers for giving me this opportunity. Am I audible?
Not very clear, sir. Can you adjust your mic?
Okay. Hello.
Yeah. Now it's audible.
Okay.
Yeah, you're clear. Yeah.
Yeah. Thank you very much, sir. before I move on, I would just mention one word about my organization. I am working at nuclear fuel complex, which comes under Department of Atomic Energy. We manufacture nuclear fuel and we supply to all the nuclear reactors in our country. So it's basically industrial unit under Department of Atomic Energy. And, as you all know, WHO declared a pandemic during December 20. First case was detected in our country in the month of January. First case in our organization was diagnosed in the month of June 2020. So before that, our medical section, it was ready and we were proactive since the declaration of the pandemic, and various measures including health education, uh, then sanitization, proper sanitization, and providing personal protective equipment, and a special COVID desks were installed uh, to extend the consultation for the beneficiaries. And as you all know, the first wave, there was no information at all about the investigations as well as the treatment part. We were evolving from that to now at present state. So whenever we all know in the first wave, if anybody is detected COVID positive, there was a stigma in the society. We used to take the recordings. We used to see people who comes to our home to collect the people or collect the sample in a COVID total PPE kits. That was the situation, and only government hospitals, government institutions were providing the investigation. So at Hyderabad also only one hospital was declared as a model hospital to extend the treatment as well as to provide the diagnostic facilities. So we were in a panicky situation in the first wave, and we used to refer to the government hospitals at that time. And at our dispensary setup, so, anybody who is suffering with fever, cough, influenza-like symptoms, we have established one COVID booth which we fabricated and erected with the help of our engineers, which provides contactless examination of the patient. Two doors were there. So one door, patient will enter, and on another side, a doctor will examine. So whoever is suspected, we used to keep them in the isolation area, and we used to refer him to the government institutions for investigation. And initially, only when the RT-PCR came into the was advised by the specialists in the hospitals, we had a negotiation with the, because it's an industry, and we had a negotiation with the government institutes to provide investigations and treatment for our employees. So, apart from providing the preventive aspects in the shop floor areas, the suspects were isolated, and they were referred to the government institutions for proper investigations and treatment.
Yeah, thank you, Dr. Vijay. So, well, because for want of time, let us concentrate more on the testing strategies. That's what we were discussing. Of course, we had a very great insight from you, sir. So I would invite Dr. Sandeep. So what was your strategies, sir, in first wave? Were you conducting mass testing, or what was the testing for workplace entry during the first wave?
Yeah, thank you, Dr. Guruprasad. Actually, when this COVID pandemic started, so we had only RT-PCR as a reliable test which was available, and it was an authentic test for testing COVID. So everyone was going for RT-PCR testing only, and in Indian Oil Corporation, we test whosoever was symptomatic or whosoever was found on contact tracing. We were going for RT-PCR tests only. Later on, when these rapid antigen tests were available, still there were not many doubts, but symptomatic cases we were doing, and for screening also we were doing the rapid antigen test. But whosoever was even false negative and he was symptomatic, he was again tested for RT-PCR. So we were having that dual strategy at that time. Means you do the screening with rapid antigen test, but if the patient is symptomatic and is negative on this screening test, then he has to go for RT-PCR. So this strategy was quite fruitful, and since all our business is an essential business and we have to run the continuity of the business, so at locations we had conducted mass testing also. So wherever these strategic locations were there, so before entry testing was done, and even people were asked to stay back to create a biobubble in these strategic locations. And in societies, in townships, we had conducted mass screening also. So this was the strategy during the first wave.
Yes, so thank you, sir. We'll come back. And Dr. Kamala, so what was the strategy in your company during first wave? Dr. Kamala?
Thank you, Dr. Guru Prasad, for inviting me. Firstly, I would like to tell you that my company is into hydropower. So we have most of our projects and power stations located in remote hilly terrains where our projects are located. So initially we found that some people, when they were moving from either their hometown to the projects, they were having some symptoms. So they were isolated, and there were isolation centers in most of our projects, and they were monitored for their symptoms. And if they were found having any symptoms, rapid antigen tests were initially done. And if they were found negative, then we tried to get their RT-PCR tests done. And in our corporate office in Faridabad also, the first case we found was in last week of May 20. And there we were able to get RT-PCR done. We did the contact tracing, and we called the lab persons and got all the contacts tested for RT-PCR, which was a lot of senior people were there, and most of them were negative. So we finally quarantined the person who was found positive and treated them with medications at home itself. So initially it was rapid antigen. When there was a mass screening was done, it was done with rapid antigen. And whenever there was negative testing, we were checking for their symptoms. And if we found that they were symptomatic, then we went for RT-PCR.
Thanks, Doctor. Dr. Ramanjit, so how was it in the first testing, and how that improved in the second testing? Of course, second testing, lot things have opened up. So how was it, like first testing and the second wave testing? What was the difference you found in your organization?
So in the first, wave, I was with different organization. So I have a diploma in sports and emergency medicine as well. So at that time, I was a physician with Punjab Football Club. I used to look after around 8 teams, around 100 players. And along with, I was consultant with the corporates as well. So I got good hands-on experience in developing the SOP along with coaches, kitchen staff, kitchen team, admin team. Yes, RT-PCR was the only test available. And the biggest drawback, no doubt RT-PCR has a good sensitivity, specificity, but the reporting time was the issue. You usually get report on the second or third day. And between 2 days, what you do, you need to put the patient in isolation or quarantine. That was a challenge. So my experience with sports team was that. So, different organization opened up at different time, depending on it was a food industry or what kind of industry it was. So when we opened our club for sports club, the challenge with me was to invite 100 players back with all the protocols in place, including travel protocols. So we told them, each and every player has to undergo RT-PCR at its home place. So with negative report, we provided them tickets to come back. And once they reach in the hostel, so we put them in under quarantine. And we conducted day RT-PCR on day 7.
This was doing second wave, Doctor? Second wave?
Second wave, yes.
Yeah, okay, yeah.
So I'll come to second wave. The biggest advantage industries got in the second wave was the rat test. So what we did in our industry, we put a different, location-wise industries into tier level. So what is tier level was basis indicators. What is the cases per million in your local area? What is the reproductive rate of the virus? What is the bed availability? So if it is towards the low side, we call it tier 1 or tier 2. Say for my industry, if it is tier 3, which means a moderate to severe case overload in the community, which means more around 200 cases per million, say, or bed availability is less, say 80% beds are occupied, then I am in tier 3. So tier 3 means we have a testing plan of rat, which means 100% of the population has to undergo rat test every week and at the entry only. So we hired agency, rat testing at the entry. The employee has to wait for 15 to 20 minutes. If the report is negative, he will go inside. If the report is positive, he has to go to isolation. So this was the, plan for the second wave. In short, although things changed, vaccination came, then we came from one dimension to bi-dimension. If the vaccination rate of the industry is towards 80%, then we reduce the testing to say 20% of the people, or only the vulnerable or the comorbid people will undergo testing. So this was the plan in brief about the rat testing in the second wave. This is the tier system. If your cases reduce, then your vaccine strategy, testing strategy will reduce to say, suppose you are in tier 2, the cases are less, under control, bed availability is okay, not very good, but okay. Then you have to undergo 50% of the population, including everybody above 50 and everybody with comorbid condition. That is mandatory for them. And 50% of the population every week has to undergo rat testing. This is the
So
plan.
thanks, Doctor. We'll come back to you. And Dr. Vijay Rao, so what was the strategy for the second wave? Because the tests were available and people were, okay for the test. Did you do mass testing? And was it beneficial for our organization if you do mass testing? And what was the frequency?
Yeah, we never did mass testing. Actually, we proposed to our management, but our management.
You're not audible, sir.
We never did mass testing, sir. Our management was not in favor of that. But during second wave, even private agencies were given opportunity to do the testing. So number of labs were available because it is in Hyderabad. Number of private agencies were available, and even the cost of the RT-PCR was brought down. Subsidy was provided by the government of India, and our organization encouraged reimbursing the RT-PCR charges. The same protocol was followed, what we followed in the first wave, like suspects were kept under isolation till they get the symptoms. Then if they are symptomatic, and we used to advise RT-PCR, and we have established the lab in our organization itself. Outside agencies used to come and collect the samples, and the same day evening we used to get the reports. So once the report is positive, we have to advise them home quarantine. We used to provide the home care kit, which contains all the medicines in the residential area only. We have converted our guest house, we have converted our community hall and CSF barracks into isolation wards and home quarantine wards. So when compared to first wave, second wave was very easy, and more avenues were available for us to help our employees.
Sure. So more testing and testing was also welcomed by the employees. That's a good sign in the second wave, what we learned.
There was no stigma at all.
Yes, absolutely right. Yes, and people accepted COVID as part and parcel of their lives. And Dr. Sandeep, like, how was it in the second wave? What was the strategy you adopted? Any mass testing or the workplace entry testing was adopted?
Actually, during second wave, as you all know, that it was a very fierce wave, and lot of devastating effects were there because of the second wave. And even if one person was affected in a family, the whole family was affected. So in that case, and even RT-PCR test reports, they were delayed. So what the strategy, what we adopted, we procured this self-testing kits, and we had distributed them in our offices, in our strategic locations. So initially, wherever there was a symptomatic case or some contact tracing was there, we did rapid antigen test if required. If it is false negative and patient is symptomatic, then we go for RT-PCR. So we were totally not depending upon RT-PCR because the results were delayed and the tests were also very in limited locations they were available. And then we also procured this point of care, this Epid ID machines also. So these machines were installed at many of our locations where one of the healthcare worker or non-healthcare worker, they were trained. It can be done by any non-medical staff also. So these boys, they were doing the RT-PCR, this point of care testing with this Epid ID machine, and that was quite sensitive and quite specific, and the results were within 15-20 minutes. The results were there. So at all strategic, many of our strategic locations, we were having these machines. Then, as I told you, these bio bubble norms, they were strict now, because we never wanted any of our LPG bottling plant or fuel terminal to be closed. So the staff was asked to stay back for a few days. Then alternate shift arrangements were made for these people. They were tested. If they were negative, they were brought to the location and the previous shifts were relieved. So in this way, for continuity of our business, this strategy was adopted, and whosoever was positive or like symptomatic, or he was having any contact history, he was definitely tested, and testing was very liberal and means
On the need basis, can we take that way, sir?
yeah.
Okay. So thanks, sir. So coming to Dr. Kamla, so what was your strategy, madam, in second wave? Did you do a mass testing? Because many companies did. You know, some people were, some
Yes,
companies
sir.
are doing once in 4 months, 5 months. You know, that was not right. And some companies did every 15 days. And we know
Yes, sir.
our
Yes.
company counterparts in Russia, they do even now every 3 days. So what was the strategy your company adopted in testing?
Yes, Dr. Sab, we were doing it every 15 days. Our Ministry of Power had sent a guideline that we need to do an RT-PCR testing camp every 15 days. So we were doing RT-PCR testing camps every 15 days. So we had hired Metropolis or Lal Lab people who used to come and do the camps. And we used to screen and see whoever was positive. Accordingly, their contact tracing was done and treatment was provided. Whereas in our project areas, when our employees were going to different states, there also they did their RT-PCR test and then they entered that state. And similarly, when they returned back also, they did their RT-PCR while returning, so that they are not infected or when they come back to their office stations. And the places where RT-PCR was not available, rapid antigen was done in our locations.
Yes, madam. Thanks for that. The travel, testing was most important at that particular time. You know, when
Yes,
somebody travels, in some companies, we used to quarantine them for 5 days, test them on 6th day, and then if they're negative, allow them inside. That was standard practice followed. And coming to the present scenario, I want to go to Dr. Rajesh Jain. Sir, what is your opinion, with the vaccination rates in India? And, people are, somewhat, if you say the entire population, eligible population, they say 68% is first dose vaccinated and 38 is 2 dose vaccinated. With that, what should companies adopt, sir? Should we test everybody in the company or only on need basis? What's your opinion, sir?
Interesting situation. Exactly like what you find in UK, we may be in the same situation. What we need to focus is the detection of the type of virus, because variants will bring in the new wave. So it's not the vaccine status which determines the testing. Number one, all symptomatic need to be tested, primarily based on rapid antigen testing if we presenting early in the from the history of symptom. First 5 days, rapid antigen test is very, very effective in multiple ways. It enables you to isolate, detect contacts, and also ensure isolation of a large population and prevent them from further spreading. And diagnostic possibility for rapid antigen in the first 5 days is higher than RT-PCR. If the history is longer, then RT-PCR may give you better results. And we have seen this in our actual clinical practice. Now, if we understand where is the danger lurking in the backyard, it is the variant of concern. What does it mean? We have to connect our sampling strategy with the Center for Genomic Analysis. And each area in geographical location in the country has been linked with a genomic testing strategy. What is required at the current moment, and this will be increasingly required, we have to increase our sampling for genomic testing. We don't have to restrict ourselves to rapid antigen testing and the RT-PCR, but we have to expand to genomic analysis so that we could detect the variant of concern, the type of variant of concern early, and take necessary action on the ground.
So in this testing scenario, sir, like for example, somebody has traveled in a flight, would you advise the RT-PCR test for him before coming to workplace now at this scenario with full vaccination?
Let me complete the previous
Sure,
scenario.
Please go on, sir.
I had gone to the one situation where we have to go to for genomic analysis. On the other side, the point of care test has to expand. That is testing at home. Self-testing will be further becoming more rampant, more common as people, as I showed you the drug, oral drug requires to be given very early. For that, the person should be given the competency, help, and the freedom to test himself. Today, that self-testing kits are available at very, very reasonable cost. So that awareness generation within the workmen or the people concerned has to increase as time goes by. So the two extremes where we have to tie up together along with the existing strategy of rapid antigen test for early testing and RT-PCR test for 4-5 days onwards based on the symptoms. For non-symptomatic, there is a problem because of the cost-benefit analysis. As you were telling, like I'm working in a transport sector, which is an essential part of the economy of this country. None of the pandemic phases in India, railways could not afford to stop because this is the lifeline. Supplying food grains, energy, everything is connected with railways. And railways works 24/7. None of the lockdowns could stop railways from working. And we have more than 1.3 million employees and their families, only 40% residing in railway colonies, 60% residing outside railway colonies. So they have to travel and function. And the nerve centers testing, the crucial component of railways working are the control officers. Those people have to be tested on a regular basis. So we were talking about mass testing. So those people who are sitting in the control center, the nerve centers, they actually were tested once every 15 days. Fortunately, we have our own infrastructure, our own laboratories, our own microbiologists, our own laboratories connected with the ICMR portal. So that became easy. But the second part that you mentioned is equally important. Now, the people who are traveling in trains and also by flights, they need to be tested based on symptomatology. Mere screening by temperature is not sufficient. So what we follow is the self-declaration. And if the person feels that he has symptoms, now if you travel in the railway stations, you must have found the district administration has set up a booth for RT-PCR testing, where the data, contact details of the individuals are taken, and people are voluntarily coming to the testing table at the railway station also. What I have seen in New Delhi station and Old Delhi station, Nizamuddin station, I have found whole family is willing to come and give their sample. So that's a great change. Earlier they were reluctant. Now people are willing to voluntarily offer themselves even without symptoms for testing. So for transport sector, for the people who are traveling, migration, they need voluntary testing facility instead of making them compulsory. Our strategy has to be more in terms of making people aware that this testing is to help them, their family, and their community. By only that means the reassurance of vaccination along with testing will work. So we in fact are using vaccination only as a supportive strategy. Testing continues as it was because we find only way to prevent a very high upsurge of the third wave or any other wave will be testing, testing, and testing. And that too on a regular basis, both RT-PCR and rapid antigen supplemented by a reasonable number of samples being sent for genomic analysis.
Thank you,
So
sir.
that is what
Thanks
we
for
are doing.
that, sir. Yes, testing, testing, testing. So, Dr. Ramanji, so what's your take on if somebody takes a public transport and what's your advice and what's your strategy for testing right now in the midst of vaccination?
Yeah, where I mean the seropositive rate is on the higher side in COVID looks under control in India. If somebody is traveling, first of all, it depends. You mean the travel within India?
Yes, travel any public transport or daily commute to office in a train or a metro. Would you advise them testing regularly?
Well, if the person is fully vaccinated, I would not advise testing for 3 to 6 months. It may be three for some regions, of some industries, maybe 6 months, because we believe the vaccine remains effective for 5 to 6 months. So we can bar them from testing for 180 days. The only concern which comes out, the person may get infected, may remain asymptomatic, and may spread infection to the others. That is another point of debate, what to do with these kind of asymptomatic cases. But obviously, I feel that testing is not advised for at least 3 to 6 months. That varies
So,
from industry to
so
industry.
we should give the advantage of vaccination for the employee.
Yes, yes, yes.
Okay, Dr. Sandeep Sharma, what's your take on this? What should be the testing strategy right now in the midst of all the vaccination going on in the country?
No, actually, now the time has come when we should start to learn to live with this particular virus as a normal virus, which other viruses like flu virus or any other virus. We have to learn. We should not take it as a stigma, and whosoever is getting either they are getting symptomatic, or if the disease is prolonging, or if they come in contact with someone who is positive, or if they are at high at a risk, means if they have traveled to a location where the cases are endemic and the cases are on rise. For example, like if someone has traveled to Kerala or someone has traveled to Maharashtra, for their self-interest, they should get themselves tested rather than getting everyone tested. It should be selective. It should be person-based, and it should be as per the requirement of the person and as advised by the physician concerned. Because otherwise, this testing it will become a menace for everyone, and if we implement it very strictly, then it won't work also, because people will not get themselves tested, and even the symptomatic people who require testing, they will not opt for testing. And now what is happening, there is a lot of resistance for testing also, because vaccinated people, they say that they have already been vaccinated, but they have to remember that vaccine can only decrease the severity of infection or the hospitalization, and still they can be carrier for infection. So it is personal choice of a person, and the symptomatic cases, and as per the requirement, if we should get for the test, not the mass testing for everyone, or we should make some mandatory rules for testing. It should be by choice.
Yes, Dr. Sandeep, totally agree with you because now we are all corporate doctors. We have to ensure the business runs,
Yeah.
and business runs, the travel also increases, and we have to support that. So, Dr. Kamla, so what's your take on this? So what's your opinion that what should be the testing strategies for all the organizations with in the middle of vaccination going on in the country?
Sir, I agree with Dr. Sandeep completely. Persons who are visiting the states where there is high infection rate, like Kerala, Maharashtra, Northeast states, Calcutta, they should get themselves tested once they return. But otherwise, if they are traveling by metro or bus, I think if they are wearing their mask, I don't think that they need to be tested, because for daily commuting, many of the employees are using these public transport. So I think if they have any symptoms, we can think of getting them tested, but otherwise, day to day, we don't need to get them tested.
And even if you don't need to test them once, then you have to test them very frequently.
Very
Every 30
frequently, I agree.
weekly.
I agree.
Yeah.
Because now we are seeing a lot of fevers which are dengue or viral fevers. And we are seeing that COVID RT-PCR is all mostly negative. So I think those places where states where there is increased frequency, we should ask the employees to get themselves tested.
So basically, you should check for the test positive rate in the region,
Correct,
TPR
correct.
region in the region, and then think of it. So
Yes, sir.
there was a question also from Dr. Samir Chowdhury. He asked the same question: with vaccination catching up pace and almost 100% vaccinated, what should be the testing strategy in any organization? Which test to be used? How to convince management for the same in view of prevent laxity of country level as far as testing is concerned? So his question is, if the corporate is vaccinated 100%. Do we need to be very stringent? That's what we discussed. Who wants to take this? Anybody can.
May I answer this?
Yeah, please go on.
The question is asked by
Dr. Samir Chowdhury.
Yeah. So
from,
Dr. Samir,
Hitachi
I
Power
still
Grids.
believe we cannot say no to the testing 100%. I still believe we should see the location of industry. What do I mean by location? Means how many cases per million, or how many cases are coming in that particular location, in that state, in that district. What is the test positivity rate of that area? What is the healthcare facilities in that area? What is the reproductive rate of the virus in that area? And basis that, we should plan testing. And what is most important is the vaccination status of that industry. If the vaccination status is more than 80%, it is very good. Then we should limit our testing to still a vulnerable people. I mean, people above 60 years of age, people above 50 years of age, just to protect them from the severe diseases, although they are vaccinated. But still, they are still, I mean, the cases which may get severe if they get infected. So this is my take on, we should consider all those indicators before planning any testing strategy right now at this moment, when the vaccination is, say, in most of the industry, it is more than 80%. Or another plan is that we cannot stop. We can recommend testing will restart. Some industries is 3 months, some industries is 6 months, because at that time the antibody levels may reduce. So these are still some debatable, but we obviously suppose now the first dose we all must have taken at the beginning of the year. So now we are in the 10th month. So, and second dose is, I mean, 6 months plus for most of the industries, or maybe half of the industries. So I think a time.
I think you're not audible. Okay. So we have heard all of panelists. Yes, sir. Please go on, sir.
Yeah. This is an interesting situation, actually. The myth that vaccine prevents infection is definitely a myth. Vaccine is not intended to prevent infection. To prevent infection, you need to have good ventilation, mask, and social distancing. 1, 2, 3. So vaccine effectiveness is increased substantially if supplemented by ventilation, masking, and social distance together. Now, if there is history where this has not been adhered to and the person is symptomatic, go for testing early. And early testing means rapid antigen, because the positivity rate is higher. Later, RT-PCR. And this is what we are doing. And this kind of detection supplemented by genomic analysis is the only way forward. Please understand the data. Even people with 2 doses and 14 days gap of Covishield are not 100% protected from hospitalization and death. If you look at the data, it's very clear. So you are more likely to be not hospitalized, you're more likely to be not die, but there is no 100%. It's an epidemiological terminology. Vaccine efficacy has to be understood in individual context. The numbers, people tend to see 70% against Delta variant as 100%. It is not. It is not. The best vaccine in the world is not protecting against Delta variant. And Delta variant is evolving very fast, faster than people think in India. That's the mistake which was done in UK. And they have the fastest evolution of the Delta variant. And please see the data. I showed you the graph. Delta variant is evolving faster than anybody in India thinks of. And the genomic analysis data that is available, there are variants within Delta variant, which we do not know how they respond to the vaccine. So vaccine is subsidiary in the debate for testing. Testing has to continue with rapid as well as RT-PCR. Eternal vigilance is required because of the simple reason that pandemic is still there. Pandemic only means it's a global infection, not a regional infection. In India's backyard, Bangladesh, Nepal, Indonesia, Russia, China are affected. And people in India, UK travel is very common. India, UK travel, we think it's not that common. It is more common than we think. People live in communities and our mobility has increased tremendously. So the transfer of variant of concern, predominantly Delta and its further variants, will drive, of which we do not know how the vaccine is going to protect. So be on your guard, continue with ventilation, masking, and social distancing. That is the only way vaccination will help to some extent. Right? That is the
Thank
way
you, sir.
I think.
Thank you, sir. That's what we saw in Israel data as well. Israel most vaccinated, still they had huge cases. That's what we are seeing in UK, and we saw in US as well. And even Singapore now we are seeing now a lot of cases. So vaccination is not a solution, but testing should continue. That's what we say whenever we see the test positive rate. Also check the number of tests done, because the false reduction test should not bring the positivity down. So that we should be very careful. So I'll just open up the forum for the panelists. We have many guests with us. So anybody wants to speak? Dr. Ashish, to start with.
Hi, I think first of all, an excellent session. I should say, Dr. Guru Prasad, you have done justice by moderating it nicely. It has been good to hear the views of several experts out here. And I think this is a topic which has different ramifications at different moments of time. For us at GSK, the approach has been constantly evolving. And as we have been looking at it, the key for now is that testing are essential whenever we are having people who are traveling out, or if we are having an inflow of new contractual staff who might be coming from different places. But I think the focus is on vaccination, and as we evolve and as we go forward, testings are done more in order to actually check how the controls are in place. So it's still evolving, but I think it was wonderful to hear the views and how each of the industries and experts are looking at it. For us, it's going to become much more pertinent as people are going to travel beyond the country as travel opens up. Singapore testing is mandatory for people on a weekly basis when they are coming to the offices at GSK. In US, we are also looking for testing. In UK, testing is a regular feature which is happening. But it's something which is more mandated by the country regulations and the country situations. So we are listening to all of them, and as we evolve, we would still be considering changing or evolving our policies further. Thanks for the opportunity.
Thanks, Dr. Ashish. So always, companies who have headquarters in UK or US, always our policies are influenced by them. For example, the UK and US don't have mask mandated in offices. That again is a big question for us. We have to answer so many questions for that. No, in India, it's a regulation that you have to wear a mask. Of course, companies are influenced by the US and UK policies. That's fine. So Dr. Kishore. Can you unmute yourself? Okay, Dr. Tyagaraju, your view, sir?
Hello.
Yeah, Dr. Kishore, you can go ahead.
Yeah, it is a very good discussion, and all the speakers emphasize on the testing. That is, I think, solution and vaccine is also 100% not preventive. As far as the Dr. Jain sir rightly said, the Delta variant is the vaccine is not effective against Delta variant. So initially in the first phase, it was a very challenging job, but at the second phase, we were so much comfortable, and all the infrastructure and resources available, and at the same time, see management in the industry, and at the same time workers, contract laborers, all they are so helpful to each other. It was excellent coordination in the second phase, but definitely the first phase was definitely very difficult. And as far as if we talk about our city, there are only few labs were authorized. Then later on for the second phase, some other labs are also authorized. So it was comfortable. But when the conclusion of this discussion is just to continue selected cases for the testing, and that is first of all the rapid and need-based RT-PCR. At the same time, we have to promote people for vaccination also. So that is there.
Thank you, Dr. Kishore. Dr. Tyagaraju.
Hear me, Guru Prasad?
Yeah, I can hear you, sir. Yeah, please.
Yeah. Thank you for giving me an opportunity to talk. See, when a patient's fever cases comes to us, actually we are 97% vaccinated in villages side, and in urban side we have morely around 85% we have vaccinated first dose, and second dose around 65% we have vaccinated all the public. So whenever a fever cases comes to us, first of all, we will find out whether this patient is suffering from malaria, urinary tract infection, typhoid or dengue or influenza, we will see. The first and the foremost question we ask the patients is whether he is vaccinated or not. In case if he is too vaccinated, we do not want to subject him to RT-PCR test because it is very costly in Bangalore in public sector. But in private patient, in government patient will not go. And that is the one we do. And in industry, we have vaccinated completely, fully, even contract laborers, family, everybody we have vaccinated in and around the Bangalore and industrial area. So whatever the case comes, we will not think of COVID. But unfortunately, we have seen some of the patients who have gone to corporate hospital has become COVID positive, and the management of COVID positive, even after the vaccination, we have seen some of the cases have, we have lost some of the cases. This is my view, Dr. Guru Prasad.
Sure,
thank you very much
thank
for
you,
giving
sir.
me an opportunity.
Thank you, sir. Thank you. Dr. Shampingla, sir.
You have to unmute.
No, you can unmute. He's a panelist. Yeah.
Hello.
Yeah,
am I
we can hear
audible?
you. Yes, sir.
Yeah.
You're audible, sir.
Good evening. Interesting discussion and very nice to see the practical aspects and people who work talking about it rather than the academicians coming and talking about it. So this is really useful. My take is initially our approach was dictated by fear and panic. Fortunately, the fear and panic has now reduced, so we should be able to take more rational decisions. Since the situation is dynamic, what we have seen in Europe, what we have seen in other places, that they came down and then they have increased again, especially UK and Russia, they are very bad. Russia, at least vaccination was a failure, but in UK there was enough vaccination. In spite of that, they had a problem. So we will have to have a dynamic approach. And what we do today may not be done tomorrow. Tomorrow the situation may change. If we have another wave or if we have more cases, we will have to accordingly change our testing strategy, vaccination strategy, everything. We as occupational health physicians should not be playing to the gallery, should not be listening to what management tells us, but we should be advising the management what is right. We have to be conscious keepers of the management and we have to be firm in our opinion. They may not listen to us, that doesn't matter. We should not give the advice they want, but we should give the advice which is right advice. Masking and social distancing is much talked about, but how far it is followed, we do not know. In the roads, we do not see it at all. And in the industry also, whenever there is a supervisor or someone who is looking around, definitely people will follow it. But when the moment you turn your back, I'm not sure how much they will follow it. It will be more or less like safety appliances the way. So therefore, we have to keep that into our mind. And yes, we have to learn to live with the virus like H1N1 and all. We are living with it. We have to learn to live with this also. Genomic testing and other things will definitely give us a clue as to where we are going. And we'll also have to see what is the TPR and what is the public health. So we need to have a very good connect with the local public health. And what is happening there, we should know, not from the newspaper, but from the people who really work there. Because sometimes we get filtered news in the newspaper, but if we have a direct connect, we definitely get more revealing information. Okay, thank you.
Thank you, sir. Thanks for your wonderful thoughts and insights on this. Thank you very much. Now I invite the attendees. Anybody wants to speak, you can unmute and speak. Dr. Anmol, Dr. Vishwadeep. Yeah, you can unmute yourself. Dr. Chitranjan.
Thanks,
Dr.
Dr. Guru Prasad and
Yeah,
Dr.
Vishwadeep,
Vishwadeep
please.
Walia.
Yeah, please. Yeah.
Hi. So very, very interesting discussions, and I echo all the learned panelists that testing is very much required as well as we go forward. However, the fear has reduced considerably, and that is we should actually not play to the gallery. We should advise the management. While we advise the management, we should also keep the science in the perspective. And like Dr. Ashish Jain also said, the science is evolving continuously. We are closely watching what the government policies also are, because government is opened up completely. And if we enforce testing on our people may come up and say that everywhere they don't test us, why are you testing us in the companies? However, there is, and I'm quoting the legal experts here as well, that they say that vaccination may not be a mandate. We cannot make vaccination mandatory, but if we need people who have traveled by high-risk modes of transportation, have come from countries where the risk is high, have come from hotspots, we can definitely subject them to testing and rapid antigen testing. We have certain kits like Abbott PanBio, which has a good sensitivity and specificity, and we are doing a great job in screening our population who are coming from these specific sites. So it also helps our sales force who are in dispersed locations to keep themselves safe. But we give them the self-test kit, testing kits, so that they can test themselves if they feel that they need to screen themselves to stay safe while they conduct business for us. That's it from me. Thank you.
Thank you, Vishwadeep. That was a very good thought, like giving test kits for everybody. So once they have fever, they can test themselves. That's really, really good. Industries who think of that. Instead of going RT-PCR, I think the more practical way of dealing it is this kind of test actually. Okay, so I'll invite Dr. Anmol, Dr. Chitranjan, Dr. Damodarli, Dr. Dharmesh Parekh, Dr. Anand Krishna, Dr. Samir, Dr. Sultana. Anybody, please, you can unmute yourself and ask any questions or give your comments here, please. Dr. Anand Krishna, yeah.
Dr. Guru Prasad, one point I wish to add here is We both during first wave and second wave, in many industries, the lab people forced themselves in and conducted mass antibody testing, which was irrelevant, irrational. So slowly people realized that, but it was there both in the first wave and second wave. I wish to add that point to you. Otherwise, the presentation has covered all the points that is relevant. Thank you.
Thank you, Dr. Anand. Thank you, sir. So anybody wants to add?
Yeah, as Dr. Anand Krishnan has said, that screening for these antibodies, it should not be promoted in the industries. And we are not promoting it, and we are telling people, and we are making them aware that your immunity from COVID, it is both cellular and antibodies. Even if your antibodies levels are low, it doesn't mean that you're not protected. Maybe your cellular immunity is working, and it will. So they now they understand. So in many cases, when they were tested positive and their antibody levels were also not matching with that, so they were causing a lot of issues that my antibody levels are good and I am tested positive. So this either the test is wrong or the antibody levels are wrong. So a lot of confusions were there. So it is better to avoid people, ask people not to go for testing for the antibody levels.
Yes, that's right. That's right. That's a very takeaway point. Unnecessarily things are done when people don't know. I think it's our duty as a doctors in industry to advise the right things to the industry. That's really good. So if you don't have any questions, any comments from anybody, or we can close the session. Any comments from the attendees? Anybody wants to?
Availability of self-testing kits came in the discussion, and I feel the time has come in offices, workplaces, and factories. Like you have occupational health centers, one must make it visibly available. Now people are more aware how to use these self-testing kits, and they should be encouraged to use them and report, because you must understand the self-testing kits have an interlinkage with the platform of ICMR. The data gets recorded. So that's a wonderful tool to enhance the usage of on voluntary basis based on the need as felt by the workers, whether they are in offices, workshops, factories, or any other place. But that will be useful take from today's discussion.
Even before getting tested from outside, this test kit, they are now families, they are quite used to use this test kit. And before going to the ICMR platform, if they see the test line and the control line, and from that they can identify that whether they are positive or they are negative. And if they are symptomatic and they are the test is coming out to be negative, they should definitely go for RT-PCR. So it is quite good screening tool at home for everyone. Yeah.
Sure, sir. So I think this panel has answered many questions, especially the practical way of dealing. So a lot of industries had this query of what test to do, whether we should do or not. So this panel has given us the practical applications, what test to we do, what test we should do, what scenarios, what strategies we have to adapt. Really, it's a great takeaway for all the industry doctors participated. Of course, the recording will be there, and many people will watch later as well, because it's festival time, and many people will watch later and get the insights from this talk. So I thank all the panelists for joining the session. It was an excellent session. Thank you for your time. Even with facilities, I can see all the, tilaks, all the foreheads, sir. You're all with all the, in spite of the festivals, you have come for the session. Wonderful session. Thank you very much. Thanks all. Thank you very much.
Thank you so much. Thank you.
Thank you, sir. Thank you all.
Thank you.